We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Welcome back, friendly listeners. And Jesse, how's it going?
Pretty good here. How about there?
Oh, it's good. Hey, I'm just going to jump right into it, okay?
That sounds great.
Why do bacteria like nitrates so much?
Oh, gosh. I don't know.
They're cheaper than day rates.
Good one.
Thank you. All right, moving on. Thanks for indulging me.
I think that's why our listeners listen to us, is just for the jokes.
Just for the jokes? Is that why we get so many downloads?
Yeah.
Oh, well, they're going to want to hang in today for sure, because we're going to be talking with Irina Rajakumar to hear more about her research on the impact of C. difficile length of treatment on rates of recurrence in patients on concurrent antibiotics. Irina completed her Bachelor of Science in Pharmacy in 2008 from the University of Toronto and a Year 1 hospital pharmacy residency in 2009 at the London Health Sciences Centre. Since then, she has practiced extensively in both hematology and oncology and infectious diseases and antimicrobial stewardship, gaining board certification in infectious diseases in 2018. Irina has precepted many pharmacy residents and residency projects, publishing several peer-reviewed manuscripts. Currently, she is a pharmacy clinical practice leader and a Year 2 infectious disease and antimicrobial stewardship pharmacy residency coordinator in Alberta Health Services. So welcome, Irina.
Thank you so much.
So let's just dive on in. Can you tell us what prompted your study and talk about the study design that was used?
Sure, yeah. So as an infectious disease pharmacist, myself and my colleagues would routinely kind of observe this practice where our colleagues at the ID physicians would recommend extending the duration of therapy for C. difficile infections if the patient was also having to continue on their concurrent antimicrobials for the other infection that they had. And the CDI guidelines at the time and still don't specifically recommend this approach. And the few published studies that existed at the time looking at this question were done kind of during the time when metronidazole was used primarily, versus later the guidelines switched to recommending vancomycin. And so we thought we could look at this question and try to answer it. And so we thought we'd do it as a pharmacy residency project. And so that means it has to be feasible to be completed in 1 year. And so that meant we had to do it retrospectively. But we do have a provincial microbiology laboratory in Alberta. And so we thought we would be able to kind of utilize that and utilize our IPNC database to be able to kind of get a fairly good sample size to be able to see some associations.
That's great. So when you're talking about the patients who were included and excluded, the article noted that some patients were excluded due to receiving suboptimal therapy of less than 10 days for their C. diff. Just out of curiosity, how frequent did you find this situation occurring where the patients weren't receiving at least 10 days of therapy?
So we didn't specifically, unfortunately, report that. We did include that exclusion criteria because, having a suboptimal duration of treatment would obviously impact potentially recurrence. But when I looked back at the data in preparation for this, it looked like most of the patients were actually just missing that data on duration of therapy. So where their C. diff was diagnosed basically right at discharge, and so they were probably treated mostly as an outpatient. And so it's not that those patients were treated for shorter courses, it's just that we had to exclude them because we didn't have the start and stop dates for their C. diff treatment.
Oh, interesting. And I would assume that there may be some cases where during outpatient therapy, you wouldn't even know necessarily even if the patient were prescribed 10 days, if they actually completed their therapy at home.
For sure, yes. And we did try to capture outpatient therapy if it was started on the inpatient setting. Like we used the database that captures our outpatient prescriptions where we could. But again, we for sure can't know that the patients were taking it.
Yeah. So some of the inclusion criteria beyond having a positive C. diff toxin or PCR test was 3 or more loose stools within 24 hours, or 6 or more loose stools in 36 hours, or abdominal pain with fever. How were these inclusion criteria determined? How did you figure out whether these things had occurred?
So because we used data from the infection prevention and control database to identify our cohort of patients, this would have been done by the infection prevention clinician at the time when they were ascertaining whether this was a case of C. diff or not. And so we kind of relied on that. And then they shared their data with us using after our ethics approval. And so this was the case definition based on the Canadian nosocomial infection surveillance program, as well as the Alberta Health Services C. diff surveillance protocol.
Interesting.
Okay. Mm-hmm. Yeah. Were there any additional inclusion or exclusion criteria you all used broader than that?
No, so we used that to kind of find our patients that had hospital-associated C. difficile and then infections, and then specifically we looked at only adult patients, so greater than 18 years of old, and then they had to be on concurrent antimicrobial therapy at the same time, and so we defined that as at least a 72-hour of overlap, because we thought that would be pretty reasonable.
Yeah, okay. So you've got your population nailed down. What were the questions that you were trying to answer?
So yeah, we really were just trying to see if the rate of recurrence was actually different in the group that was getting longer treatment of their C. diff, which is what the clinicians are trying to do by extending their therapy. But because we kind of didn't know it, there's no published results to show that that's actually true. So we thought we should study that and see is the recurrence actually better.
The never-ending river of C. diff.
Right. So looking at the tables included in the article, I can see that patients were stratified by age, sex, clinical service, concurrent antibiotics, and more things than that. Did you know anything of significance with regard to any of these demographics?
Yeah, so we stratified patients by duration of therapy, but for sure we looked at these demographics to kind of see what our groups were like. And so we noted that, their age, their clinical service, and whether or not they had an ID consult was pretty similar between the two groups. On the other hand, the mean duration of concurrent antimicrobials was longer in the extended duration group by a whole week, as well as obviously the mean duration of C. diff therapy was longer. And then when we looked at the specific antimicrobials that were used between the two groups, there were more carbapenems and fluoroquinolones used in the extended duration group.
Interesting. And it also mentions that some of the patients had a consultation with an infectious disease physician. Do you think that had an impact on the subsequent outcomes for these patients that had that consultation?
Yeah, so that for sure, we kind of were curious about that as well going into the study, and that's why we kind of included that as part of the data collection. we did do a subgroup analysis and in that both age greater than 65 and a lack of an ID consult were associated with a higher risk of recurrence. Now, we didn't specifically look at trying to figure out why, but one of the hypotheses was maybe when an infectious disease physician is involved, maybe the patient's antibiotics were narrower for the infection that they were being consulted for because they're kind of more cognizant of the risks of C. diff with antibiotics. But we didn't look specifically at that within those patients that had a consult.
Right.
Yeah, and along those lines, the paper notes that the guidelines recommend discontinuation of concurrent antibiotics while treating C. diff. So I'm curious if you were able to extract data on how many patients may have been on unnecessary antibiotics to begin with, especially without ID consults. So, if a patient can be discontinued from an antibiotic, did they need them in the first place?
Yes, for sure. I totally agree with you that should be the practice. And so with our project, we kind of basically took patients on concurrent antibiotics and it was basically assumed that they had to have them. We did not extract data looking at their indication for antimicrobials or their kind of current clinical status at the time, so we couldn't make an assessment of appropriateness of therapy. And most of the patients were kind of on longer term antibiotics, so they weren't pneumonias, so they were mostly longer term things that were being treated, things like osteomyelitis or endocarditis, but we didn't specifically collect that. So we can't really say, but again, the assumption is that these patients had to stay on these antibiotics because otherwise, for sure, they should have been discontinued.
Mm-hmm. Yeah. And are there other factors that you think might have contributed to the increased risk of recurrence beyond that duration of therapy?
So CDI recurrence is definitely multifactorial, and we try to look at the factors that we had in our data. So we looked at the patient's age, their previous CDI, and the duration of concurrent antimicrobials. From the literature, there's definitely other factors like, the type of antimicrobials, which we looked at, but we couldn't control for, whether previous hospitalizations, if people have had chemotherapy or a proton pump inhibitor use, and if patients come from shared living facility. So there's definitely some other factors that are not balanced between the groups, but we did try to control for all the ones that we had.
So the article also notes that the frequency of dosing was not available from the extracted data, and therefore it was not possible to ascertain the number of patients receiving standard prophylaxis or taper dosing. Had this information been available, how do you feel those variables might have affected the findings?
Although during the conception of the study, we kind of wanted to look at the relationship between vancomycin dose and recurrence. So, there's a few different possibilities where patients could be continued on their treatment dose, so 4 times a day, or they could be slowly tapered, or they could be switched to a prophylactic dose after the set duration. And so ideally, we would have wanted to look at that, but unfortunately, that data wasn't available to us from when we got it from the data analyst. But because our numbers were relatively small, I think the numbers would have been just too small if we broken them down more into those subgroups. So we probably wouldn't have been able to make any statistical tests on that and draw conclusions anyways. We would have needed a longer, larger study.
Okay. And also in the article, it notes that in some other studies, it has been shown that 5 to 25% a difference in recurrence rates between standard and extended duration therapy groups. What did you find with this particular study?
So yeah, that was our primary outcome, was looking at the 90-day recurrence, and we actually observed only a 4% absolute difference in recurrence at 90 days. So it was 22% in the standard group and 26% in the extended duration group. And so it was not statistically significant, but because our power calculation was done using that larger estimate of 20 to 25%, it's possible that it's underpowered.
Interesting.
Yeah, and in order to answer your overall question, you needed to determine whether there had been a C. diff recurrence. So how were you all able to make this determination?
So again, we relied on the provincial microbiology lab to get us the results of whether the patients in our cohort had a positive test for C. difficile within the 90 days from completing from their previous episode. So that's how we defined recurrence.
Mm-hmm. And what about the incidence of vancomycin-resistant enterococcus, VRE? Was that significantly higher in patients in the extended duration therapy group?
Yeah, we looked at this as our kind of safety parameter. And so the extended duration group had a 9% incidence versus 6% in the standard group. It didn't reach statistical significance, but it's a trend, and it has been shown in some other studies that the patients with longer durations of vanco therapy are at higher risk of acquiring VRE. And so that's why we looked at that.
Were you surprised at all by those results regarding incidence of recurrence or VRE?
No, yeah, so we hypothesized that it would be higher in the extended duration group. Unfortunately, after analyzing our data, we discovered that we couldn't tell whether the two groups had the same rate of being tested for VRE because our hospitals do not use routine surveillance for VRE. And so we don't really know in terms of the prevalence, but the cultures for VRE that were done there were more in the extended duration group.
Wow, that's interesting too. Lots of interesting information that came out of this, I think. Were you able to determine if additional antibiotics in that post CDI infection group in that 188 days afterwards were more likely to suffer a recurrence?
We didn't look at the antibiotics beyond this current episode, right? So we just looked at patients that had an infection that was being treated by antibiotics right now, and then they also had a C. diff episode at the same time. We did not look at their future need for antibiotics or future use of antibiotics. So unfortunately, I can't answer that.
Okay, that's all right. And is there any evidence to support the use of prophylactic vancomycin for those patients who have a history of C. diff infection? Because we do hear of some organizations that do that.
For sure, yeah. It's definitely a little bit of a different question than what our study looked at, but there are several retrospective observational studies looking at that question, as well as an open label small RCT that was published within the last couple of years that looked at that question. Unfortunately, the level of evidence is still pretty low quality, and so the latest IDSA guidelines do not make a concrete recommendation for secondary prophylaxis, but there's definitely some body of evidence. And I did notice there is a Spanish group that just published a protocol planning to do a double-blinded RCT looking specifically at that question. So hopefully we'll have some more information in the future, because sure that's a very important question that we're all trying to figure out whether we should do this, because these patients are going to need antibiotics in the future.
Yeah, that would be great.
Yeah, it's interesting because there's so much conversation too around probiotics and whether those work, and some studies, with conflicting information. So it'll be really interesting to see what comes out with the use of prophylactic vanc. And length of stay is a consideration for hospitals as it contributes to increased costs. So were patients on extended duration therapy hospitalized for longer periods?
Totally, yes, they were. So we can see that in the table 1. We didn't specifically report length of stay, but we can tell that because we looked at inpatient antibiotic use, you can tell that the extended duration therapy group was on antibiotics for 21 days compared to 14 days in the standard group. So that's a whole extra week of being hospitalized, looking at the patients, overall. And then the duration of C. diff therapy was also 24 days compared to 11 days. So again, that's more than a whole week of being admitted. And so definitely these patients were there for a long time.
Yeah. And, I'm curious, can you give us a little bit of insight into some of the weaknesses of the study, specifically the overestimation of possible CDI cases due to testing constraints, coupled with the lack of access to reported symptoms?
Yeah, so our the IPNC clinicians pointed that out when we were writing up our article, that definitely relying on just a positive C. diff test for recurrence has a limitation, because again, we're not assessing if patients have symptoms, and we all know that patients can have diarrhea for other reasons, right? And so if the test is done, it could be positive because they're colonized from before, etc. So there's definitely potentially some limitation of patients being kind of overclassified as having C. diff when it might not be clinically significant. However, I think the biggest limitations were potentially the sample size. So yes, definitely our IPNC clinicians pointed out when we were writing up our article that there is a limitation in using the laboratory surveillance method to define recurrence, as we could be misclassifying patients because they could have diarrhea for other reasons and still get a positive C. diff test. And so not being able to assess clinical symptoms is a limitation. However, I think the biggest limitations in our study were potentially not big enough sample size, and that the fact that our two groups were not being balanced in terms of risk of CDI recurrence, as we talked about before. So having kind of longer courses of concurrent antimicrobials and possibly broader antimicrobials, as well as having potentially more severe C. diff. And so, yeah, I think the biggest bottom line, I think, from our conclusion is that we need a prospective study looking at this question where the two groups are being able to be balanced for all of those different factors that contribute to recurrence.
I don't know about you, Nikki, but I feel like C. diff in particular is sort of a bear for all infection preventionists, because we don't know the best way to test. We don't know necessarily the best way to treat to prevent recurrence. There's just so much information I feel like we're sort of missing as part of this whole C. diff world, that we really need to we need this research. We need people to continue to do this research so that we can glean more information.
Yeah, I do feel that way. In fact, I was going to say, it always feels like we're just swimming against water, and we can make gains. We're getting stronger. Mm-hmm. We're able to fight the current a little bit, but there's always new stuff coming down the pipeline. I guess that's probably kind of punny, but how do we test to make sure we're not being too sensitive and just picking up colonization? But how do we test effectively for true? It's so much information on treatment, testing, and what we do with all that information. So, we can't get tired of C. diff for sure.
And then it impacts our reporting, and then we have considerations about how to test and how to treat based on the reporting. So I think it's kind of a huge mess right now. So I think I'm looking forward to hearing more of this type of research coming out in the future. So Irina, if you had a couple of points, one big point that you'd like to leave the listeners with about this work, what would it be?
It's definitely a complex question, and because patients have different risks for recurrence, it's quite tricky to say whether to extend the duration of therapy or not when And so I think there's definitely validity to that perspective of wanting to extend that duration because the patients are high risk on broad spectrum antibiotics for a long time. From our study, we noticed that the rates of recurrence were similar, but maybe it's because those higher risk patients were on longer therapy, and the lower risk patients were able to be fine with the standard duration of therapy. So it's definitely a complex question. And there's still lots of question left in terms of how long do we extend it for? Do we need to use the full dose or could we use a prophylactic dose? But what we noticed is, that there wasn't a difference in recurrence that we were hoping to see, but definitely still more questions, really, than answers, yes.
Yep.
I think that's a good way of putting it, is there's more questions than answers, but we definitely appreciate you participating in this work and bringing more information forward as infection preventionists that are really kind of caught up in the weeds of all of this. So thank you so much, and thank you for being here with us today to talk about the work that you're doing.
Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Althen and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.